Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about cancer survivorship with Dr. Neal Fischbach. Dr. Fischbach is an assistant professor of medicine and medical oncology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Neal, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Yeah. I am a medical oncologist, and I specialize in breast cancer. I came to Yale via Northern California at UCSF, where I started as a molecular biologist involved in what makes leukemia cells grow, and morphed into a general clinical oncologist and ultimately into a breast oncologist. So that's given me a pretty wide spectrum for all the aspects of oncology.
And so at the top of the show, you gave a shout out to all thrivers out there. Can you talk a little bit more about, we talk about survivorship. Has the term survivor been now replaced with thrivers? Can you kind of talk a little bit about that?
Yeah, I like to think so. I think when I hear the word survivor, it really implies a catastrophic thing that occurred in your life that you managed to survive. And I think we're moving more towards a model that for many, cancer is a very profound thing that happens in life, kind of a big stop sign. And from that profound thing, positive change can occur. And I think what thrivership is about is exploring tools to live your best life. And that encompasses a very, very wide breadth of services and exploration.
Yeah. I agree with you. I think that for many patients that, after you get that diagnosis, many patients actually find that it was not something that they would necessarily ever want to do again, but something that gives them a reset and a refresh and a new way to think about life that really can be energetic and a really positive thing. Can you talk a little bit about that? Have you seen that in your patient population as well? And can you maybe give us some stories as to how that's kind of played out in your practice?
Absolutely. So, Anees, I think this is one of the reasons why many people choose to go into medical oncology, because this is not a rare phenomenon. And I think anyone who's experienced something very profound and difficult in their life, whether that be confronting cancer, another illness, a major challenge growing up, all find that it can change us in some positive ways. And in truth, that's really what's drawn me to oncology, because witnessing this transition and transformation is something that I gain a lot of energy and joy from seeing. So in my profession, I've seen people who have had cancer enter their life, have decided as part of their assessment, the job I'm in, I really am not satisfied. I want to go on to do something different. And people have gone on to open their own businesses or start a career in advocacy, things which bring them in their workplace a ton of joy. And it's cliche that people might say, yeah, I really lost tolerance for all the BS and found what's important to me. But I think that really does ring true. And while that covers a lot of professional life and in truth, personal life too, I think that the healthy habits that people can adopt, just discovering the world of mindfulness and how the brain and being present can have a really dramatic impact on our mood in life is pretty remarkable. In addition to the exercise, nutrition, and all of the services that we are trying to make available to people, so as they're going through this process, they can have all the opportunities to explore. And I also want to make clear that the term survivorship and thriver does not apply only to people who had cancer in their past. This includes people living with cancer during their treatment, living with metastatic cancer. And those have been some of the most profound, I think, experiences that I've had with people who find that their life has changed in ways that you never imagined, but this would be positive even when living with chronic cancer.
Yeah. I've seen the same thing in my practice as well. People with this diagnosis all of a sudden start reassessing, not only their jobs, but their relationships. They get out of bad relationships or into new good relationships. They have never traveled in their life and they end up going and getting a passport. I had a patient who had always wanted to go skydiving, but never did. She was always too afraid. And then after she got her diagnosis on her 5th year anniversary, she went skydiving and had a blast. So I agree with you. I think it can be so positive. But Neal, if we take a step back, I can only imagine that people who are just newly diagnosed, hearing us talk about, these wonderful, magical, positive kind of reformations of people and the journeys that they've had, might be thinking, geez, this is a really scary diagnosis that I've just been handed. And especially, as you say, for people who have had metastatic disease, it can be particularly scary. And they may not be thinking about how this is a really positive experience. They may be thinking like, oh my God, I'm going to die. Can you talk a little bit about how you hold patients' hands and get them through that scary part so that they can get to the not so scary positive part?
Well, I think that is the real art of medicine, and it takes a village, as you said. I think that one of the biggest issues that face people when they're given a diagnosis of cancer is simply fear of the unknown. And that includes fear of the physical aspects of cancer and its treatment. What am I going to go through? What's my body going to be like? What am I going to lose? How am I going to live with those limitations, restrictions? The emotional fear, the emotional strain of diagnosis impact not only on the person with cancer, but their family and their loved ones. And lastly, of course, one that's starting to garner more attention at last is just the fear of the financial unknown. How's this going to impact my finances and my plan that I was to retire 10 years from now, kind of thing. And I think the best way to get people through that is to name it, to help people identify, yes, we understand your concern that you may lose your breasts or you may lose part of your colon or whatever cancer treatment may bring. And this is exactly what that's going to be like. And this is how we're going to help you live a full life. I found back in the day when I was doing general oncology and colon cancer, just directing people to a site for swimwear for those with colostomies, like scuba things. So you can be swimming, you can be scuba diving, helping people realize that, they are not the first to go through this problem. There are resources available to help them navigate these things. And not only the physical, but now one of the most wonderful things about practicing at Yale and Yale New Haven is we do have a really broad range of services to help, once we have enumerated the emotional and financial stuff, direct people to the resource that can help them with those things. But again, I think for me, I think fear of the unknown, I think we're more scared of what we don't know. And once we know it and can name it, we can overcome it.
Yeah. And I think that that's so important because I think that when you're looking at this diagnosis and you're thinking, this is going to really turn my life upside down, it is not going to be the way it was. But I think what you're saying is, okay, so it might not be exactly how it was. Because yes, we have to get through this cancer diagnosis and the treatment. But there are ways that we can make this better. And there are resources available that, can make it such that you actually can enjoy the things that you otherwise did. I love the example of the swimwear for colostomy patients. Can you talk a little bit about the fear factor of the existential? I think that especially for patients who have metastatic disease, it's not, it is in part, okay, am I going to lose my hair? But I think it's more, am I going to lose my life? Or perhaps more pointedly, when is that going to happen? And how is that going to impact my family? And I think that those scary moments make it really hard to kind of be in the moment. And when you're talking to those patients, they may be kind of like Dr. Fischbach, I get the whole mindfulness thing, but right now I'm just really scared about what's going to happen to me and my family and my life.
Yeah.
What do you say to those patients?
Well, I think the first thing to recognize is that everybody is different. Everybody has their own coping mechanism for dealing with this kind of fear. I think this is where family and caregivers are really important to help understand what's best for one person. I think for some people, having a very quantitative discussion about statistics and what we expect in the future is helpful and reassuring. And for other people, that can be really distressing. But with that in mind, I think that what I try and stress is that the brain is an amazing thing, and it handles big, world-shifting information like this in small bites. It's sort of like the aphorism of how to eat an elephant, one bite at a time. That's the way the brain works. And so starting with just a small broad overview about what concerns you the most, thinking about what is now as opposed to what may be in the future and trying to bring it back to what is now. I think that is one of the real strengths of mindfulness, and getting people to open up. I think cancer and in some respects suffering and worry about outcome and treatment side effects is a very internal kind of process. And we can sometimes spend too much time internally, and helping people start thinking again about opening up and exploring the external, whether that's via exercise or getting involved in advocacy, that type of thing. I think is a pretty extraordinary transformation.
Yeah. And I think the other piece that makes things a little less scary, at least for me, is the whole idea that, cancer treatment has changed a lot, and it continues to move and develop and get better and better. So the side effects that your Aunt Mary may have faced may be very different than what you're going to face. But first, we'll talk about all of that. But first, we do need to take a short break for a medical minute. So please stay tuned to learn more about survivorship in honor of Cancer Survivors Month with my guest, Dr. Neal Fischbach.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their survivorship clinic is a resource for cancer survivors and provides patients and their families with information on cancer prevention, wellness, supportive services, and health research. SmiloCancerHospital.org. Genetic testing can be useful for people with certain types of cancer that seem to run in their families. Genetic counseling is a process that includes collecting a detailed personal and family history, a risk assessment, and a discussion of genetic testing options. Only about 5 to 10% of all cancers are inherited, and genetic testing is not recommended for everyone. Individuals who have a personal and/or family history that includes cancer at unusually early ages, multiple relatives on the same side of the family with the same cancer, more than one diagnosis of cancer in the same individual, rare cancers, or family history of a known altered cancer predisposing gene could be candidates for genetic testing. Resources for genetic counseling and testing are available at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Neal Fischbach. We're discussing the care of patients with cancer in honor of Cancer Survivors Month. And right before the break, we were talking about how, sometimes we as clinicians see these absolutely beautiful, wonderful transformations of patients into the best versions of themselves. And while we can try to intimate that to patients, sometimes it's still really scary when you're faced with a new diagnosis of cancer and you think, perhaps rightly in part, that your world is falling apart. But it doesn't have to be that way. And I think part of it is that a lot has changed in terms of cancer therapies. We're moving forward at rocket speed in terms of finding new therapies, better therapies that have fewer side effects. And so sometimes the fear that many patients have is based on information that they've seen from friends, from family members. And so, Neal, can you talk a little bit more about this concept that your cancer isn't your grandmother's cancer and how things are changing in terms of cancer therapies today that might make things a little less scary for people who are newly diagnosed with cancer?
I think that is such an important point, Anise. I think that conveying to people that one of the biggest sources or areas of investigation over the last 10 years anyway, in my experience in breast cancer, similar to other breast cancers, is how can we achieve the same spectacular outcomes with less toxicity? And that includes even in the case of metastatic breast cancer. How do we help people live longer and live better at the same time? And fortunately, we are more and more able to realize both those goals at the same time. And so that's just, again, a exercise in trying to evoke what worries you about the treatment, what have your past experiences been, and then trying to convey what the modern approaches are. And again, emphasizing in my mind, one of the most wonderful things that's happened in medical oncology is deciding who needs treatment and who doesn't, who may safely be observed after curative cancer surgery without needing any systemic treatment. And in the breast cancer world, who with breast cancer, which may have recurred and be spread throughout the body, who can be managed now with pills, only very gentle endocrine and targeted therapies. And the era of personalized medicine, which we may discuss in more depth later, I think that's something that is really transformed oncology.
Yeah, I agree with you. But, I think for some people, they may be under the impression that, cancer being such a scary diagnosis, they may approach the whole conversation of watchful waiting or being treated with less aggressive therapies as scary in and of itself. Like, what do you mean you're not going to treat me with like the most aggressive chemotherapy? We want to fight this cancer, don't we? How do you approach those conversations?
First, it depends a bit on the situation. So in one instance, if we are dealing with a cancer that we cannot cure with currently available tools, we try and have the marathon approach. Our goal is to keep you healthy and living well in a joyful life until we have a cure or an indefinite way to control your cancer. And doing more upfront, in fact, is counterproductive. For those who have early cancer, for whom we are quite confident that less is more, I think focusing on some of the toxicities, late toxicities of treatment, which we've identified, and the confidence we have with our new molecular techniques in risk stratifying people and deciding who needs more treatment and who needs less is really one of the main tasks of the physician, helping recognize what is the person sitting across from you's healthcare values? Are they maximizing risk reduction over short-term toxicity? Or do they maximize avoiding toxicity in medicine and then helping meld that their own healthcare values with the treatments we have available? And that's really the fun of oncology.
Yeah. Can you talk a little bit more about some of the advances that we've made? I think that you mentioned several of them. So one is limiting toxicities. Two is potentially, figuring out who needs treatment versus not. A lot of that work has not been done in a vacuum. A lot of that work has actually been done on the back of really rigorous, robust clinical trials.
Yeah, so this, of course, is one of my passions. And what I try to impress upon people is we are walking a well-trod path. And all of the recommendations that we make for standard care are based on this extraordinary altruism of people who have come before and who have decided, I also want to help those behind me. And so if there's uncertainty as to what is the best course of treatment for me, I want to be part of finding out. And that's the selfless part of participating in a clinical trial, that you are helping the next generation of people coming behind. There's also a real immediate interest part of participating in clinical trials, in that many of our studies these days are standard of care plus a treatment, which we have reason to suspect may really improve efficacy, or standard of care versus something a little bit less, which we suspect is safe to do and less toxic. And that can translate into real benefits for the individual themselves, as well as for those coming down the path after.
And I think that's so important that patients know that, because that way the whole idea of participating in clinical trials might be a little less scary, because I think there are still some who feel like clinical trials are only for those who have no other option, or clinical trials are, really human experimentation, and being a human guinea pig. And I think that the way you phrased it kind of alleviates some of their fears. Do you find that patients are more receptive now to participating in clinical trials?
Yes and no. I think there still is a lot of prevalent belief that clinical trials are experimentation, and that they involve a lot of uncertainty. And here, this is the most fertile ground for me in helping people understand that just the opposite is true. So there was a time where we reached for clinical trials when people were resistant to all of the currently available treatments, and we had a new chemotherapy which we were trying to test. And not surprisingly, when giving a new chemotherapy to someone who'd been through a lot of chemotherapy, the success rates were low and the toxicities were high. Well, things have transformed in clinical trials now, where we're actually using targeted treatments based on our understanding of what's driving that person's cancer, often unique to just the molecular abnormalities in their own cancer as an individual. And we've developed rationally designed treatments for those abnormalities. And so we've seen a kind of flip-flop in our developmental therapeutics, where now those getting these experimental treatments, the response rates are higher and the toxicities are lower. And this not only applies to people who've been through a lot of therapies. My greatest joy at the end of this week, I'm seeing a woman who is 6 years out from her diagnosis with metastatic breast cancer, has no evidence of cancer in her body because she went on a first-line trial with at the time, a newer kind of medicine called a PARP inhibitor for her breast cancer with immune therapy. And instead of getting the standard treatment, she got this treatment with which her cancer has really responded beautifully. Will it ever come back? We don't know. But even for those just diagnosed with advanced cancer, I think considering clinical trials is important to do. And when we do in that setting, we recognize we're in the driver's seat. We don't have to do a clinical trial. If there's something really compelling and exciting that's available, we're going to do it. But we have these great standard of care therapies, which we can also do. And I think that's...
And I think the other point that you just made that I think is really important for patients to understand, especially when they're diagnosed with metastatic disease. I think so many patients, when they hear metastatic disease, they think cancer has spread all over my body, which might in fact be true. But the leap that they then make is, I'm going to die tomorrow. But tomorrow might not be tomorrow. Tomorrow might be 6 years down the line. It might be 20 years down the line. And we have made a great deal of progress in terms of the therapies that we have. Can you talk a little bit about that in terms of the longevity that people can have with metastatic disease? There
And this is really true almost across the board in oncology these days. There are so many new, compelling classes of medications. I'll just list a couple off the top of my head. One is a whole family of drugs called antibody drug conjugates, ways to bring cancer-killing medicines directly to the cancer cells themselves while limiting exposure to the rest of your body. And this has really transformed the treatment of certain types of metastatic breast cancer, and it's the same technologies being employed in a wide variety of cancers. We have new and different ways to harness the immune system. The bioengineering that is going into how to engage our immune system is mind-blowing, and it's happening on a molecular scale. Ways to tether your immune cells to your tumor and turn the tumors on, which are leading to dramatic responses in now largely lymphomas and leukemia, but this technology is now being expanded to solid tumors, and taking our own immune cells and reprogramming them to fight our cancers is again something that has transformed leukemia and lymphoma, and now is making serious inroads into solid tumors we never thought would be immune responsive, like pancreas cancer. So this is a really extraordinary time. And what the vignette I share with people, just on a personal level, I like to think I'm not so old. I will share with the audience. I've been practicing for 20 years, but just at the tender age of 56, I have lived already through two transformations. The era of targeted pill treatments for cancers like chronic myelogenous leukemia and lung cancer, which have completely altered the natural history of those cancer, and people are living for decades or indefinitely. And a second quantum leap, the early days of our immune therapy, where now some people, even with metastatic lung cancer, we're saying have been cured. So these changes are coming fast and furious. The way these changes happen is via access to clinical trials. And I would urge people to think of your medical oncologist, your treating team, as your concierge. Their job is to help you find the best treatment, including thinking about, are there clinical trials available which you might want to consider at all phases of your treatment.
Dr. Neal Fischbach is an assistant professor of medicine and medical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.